so that's where we left off. Then we'll go into, endocrine. We're gonna start we're gonna do diabetes today. Diabetes. Of course, not okay. So, let's see. Four. Okay. Maybe. I think it's part of the day. Fun. Okay. We're gonna start with SIRS because I know you've heard me talk about SIRS. And in SIRS, sepsis, these definitions have really truly morphed over the years. Okay, and so if you break down what SIRS is telling you it's a system or systemic, I forgot the IC or I deleted it, so systemic inflammatory response syndrome. Right? So it's telling you it's systemic, it's everywhere in the body, that you have massive inflammation in response to a trigger, regardless of what that trigger is. Okay? And so you're going to have signs and symptoms of this throughout the body. Can it occur in sepsis? Let's hear it. Like it. So can it occur in pancreatitis? Probably.
Sure.
Okay, do you have inflammation with pancreatitis?
Yeah.
If it's overwhelming enough or exaggerated enough, can it lead to a systemic reaction? Absolutely. Okay. And so that's the difference essentially between the two. Okay, and they're both gonna have this kind of exaggerated response. Okay, so SIRS can happen in sepsis. It can happen not in sepsis. So if you look at your stressors that are listed out for you, infection is one, trauma itself. And that can be any kind of significant trauma typically, not like I got a splinter in my finger, or I smashed my finger with a hammer. Okay, significant trauma, surgery, any kind of acute inflammatory condition, ischemia. So think about even, PEs and MIs, reperfusion injuries, and malignancy. So the list is pretty broad. So this is something that you have to always keep your mind on. Okay, so let's go a little further into it. Okay. Yes, you're going to have the release of acute phase reactants. So you're going to have C-reactive protein. You're going to have a drop in your albumin level. Your SED rate is going to be elevated. Okay? And the whole purpose of this, with all these protein releases, the complement release that we talked about last week, okay, is defensive, but it becomes dysregulated. So it's an overwhelming or exaggerated response that essentially kind of goes unchecked. And so when that happens, it can lead to, as you saw last week, DIC. DIC can occur in SIRS. Pancreatitis, a bad case of pancreatitis can trigger DIC. I saw this firsthand when I was working at the law firm, and I reviewed a potential case. The plaintiff in this particular case was a scientist, and all he remembers is he was having this nausea and vomiting. He went into the hospital and he doesn't remember anything. But apparently he got all these blood transfusions and all this kind of stuff, and he was sure that the hospital had done something wrong to this guy. and actually, and he was saying that they bloodlet him and that they must have caused a hemorrhage because he lost all this blood and they gave him all these units of blood and this and that. Well, when I looked at the medical records, okay, this guy had one of the worst cases of pancreatitis I've ever seen. And he had classic SIRS with DIC, with multi-organ shutdown. He was on a ventilator because of acute respiratory failure. His lungs failed. His heart was hypokinetic. He had DIC. I mean, 2 weeks sedated on a ventilator. And he made it. His cholesterol levels, his like triglycerides were in the 4,000 range. His total cholesterol was in like the 3,000 range. Never seen anything like it at all, ever. But as you know, hypercholesterolemia, hypertriglyceridemia can trigger acute pancreatitis. And he was fighting the whole thing and saying, well, I don't drink alcohol, or I didn't have this. Yeah, you did. And so, but it was my first exposure to the severity of what this whole cascade can do. Okay. Sometimes, excuse me, the organ dysfunction is actually, it becomes irreversible. And yes, people will die from this if, in some cases, they're gonna die, or they can lose body parts. Okay, I reviewed another legal case in which a guy ended up losing both of his arms. And it was because of SIRS and reperfusion injury and in compartment syndrome that developed in both forearms. For whatever reason, it developed in both forearms and he ended up a bilateral amputee at 26 years old. It all started with an assault. He was knocked over the head. So, so if you have a source for infection, that SIRS associated with infection equals sepsis. Okay, SIRS without infection is SIRS due to whatever the other cause is. But I encourage you to keep an open mind in that any of these conditions, anything that triggers an acute inflammatory response in certain individuals, and we don't know why, it becomes exaggerated. And this uncontrolled, inflammatory cascade will trigger the systemic response. Okay. So 2 of the 3 criteria have to be met. Temperature over 38 or under 36. That's interesting. Hypothermia. What do you think about that? Hypothermia. What's it telling you? You tell me. Tap into what you know. Go back to what controls body temperature. You're safe.
Metabolism creates heat, so your cells aren't metabolizing because of the infection.
Okay. Okay.
Maybe if your cytokines aren't working properly, it can't signal to the hypothalamus to adjust the set point.
Okay, so do the cytokines have to tell the hypothalamus to adjust to a set point, or is it already the set point? And if it's not able to maintain normal body temperature, what does that tell you about that organ? It's dysfunctional, correct? So do you think, and this is just a question across the board, if you have a patient who's sick and they're hyperthermic, or, pyretic, or hypothermic, what do you think prognostically, which one is gonna have the worst outcome? Hypo. See that? Your patients that are hypothermic, remember hyperthermia is a response to cytokines, and it is in an attempt to rid the body of bacteria, to provide extra heat, essentially, to make it less hospitable, I was trying to get the right word out, hospitable to the bacteria, right? All right, if you can't mount a response and you actually become hypothermic, it's telling you that you've got central organ dysfunction. That is a very bad poor prognosis. Okay. So cold mottled skin, hypothermic patient. The chance, just that alone, the chance of that patient making it drops way down, regardless of your interventions. Heart rate greater than 90. So, you know, they don't have to be technically tachycardic to have SIRS. Okay, because tachycardia, the definition of tachycardia is what? Over 100, correct. So even if it's 98, your patient is showing other signs and symptoms, that patient meets criteria. Yeah, put it in perspective. Respiratory rate greater than 20 or a PCO2 less than 32. Okay, so let's take the respiratory rate. Let's take the respiratory rate. If the respiratory rate is greater than 20 breaths per minute, tell me what's going on here. Tell me why.
CO2.
Blowing off CO2, which equates to acid. Okay. Right, so there's an accumulation of acid somewhere. Okay. And so it could be lactic acid from its tissue ischemia. So these are all signs. This is where vital signs are vitally important. Interpret what you're seeing. Don't blow off that respiratory rate of 22 or 24. It means something. If their PCO2, their partial pressure of carbon dioxide, okay, this is in the lungs, is less than 32, it's telling you what?
You're blowing off a lot of CO2 because you're acidotic.
Correct. You're trying to compensate, okay, and so, yes, you're trying to blow it off, and so it does kind of equate to an acidosis. Good. All right, leukocyte count greater than 12,000 or less than 4,000. Or 10% bands. Who wants to do the easy one? 10% bands means what? Infection, okay, what kind? Bacterial. Okay, bacterial. Bacterial infection. Bands or neutrophils. Gonna be bacterial. So one of your first responders, most commonly, this is gonna be an acute bacterial infection when you have a bandemia. Okay. So your leukocyte count greater than 12,000, well, that kind of makes sense. Okay, can you have a leukocyte greater than 12,000 and it not be infectious? Yes, absolutely. Okay, or bacterial in that matter. Pain can cause it. Seizures can cause it. So what about less than 4,000? Tell me about that. Tell me about less than 4,000. And in an otherwise normal, healthy individual. Tell me what it means.
Myelosuppression. of some sort.
It could be myelosuppression. That is a possibility. Else would you look for if it, in that particular case, if you were suspecting myelosuppression?
It'd be more of like a pancytopenia.
Could be, but it depends on the timing. Okay, could be. Pardon me? Could be an overwhelming viral infection. And in that case, what's happening? Even if it's an overwhelming bacterial infection, what's happening? Why isn't the white count going up? Why is it going down? Pardon me? Yeah, it could be if it's further in, or as Ashley said, myelosuppression, right? But what else can happen acutely? Do your white cells live and regenerate? No, how long do they live? How long do white cells live? Like 5 to 7 days, not long. Okay, and if they are phagocytize bacteria or take it to the liver, the spleen, one of your reticular endothelial organs, and they become consumed. They're dead, they're destroyed. In destroying the pathogen, they get destroyed. So a low, like a drop in white count, correlates to a massive loss of your infantry. Okay? Your Marines came in and there were mass casualties because of the number of pathogens. And your bone marrow hasn't had time to respond and release more white cells. So that puts you in a leukopenic state. Is that a good place to be? Not at all. How's that? Everybody understand these concepts? Yes, go ahead, Kevin.
So that's definitely what I thought it was gonna be, but because you had phrased it as like an otherwise normal healthy patient. So, and that happened so quickly that the patient presents as normal and healthy.
Yeah, well,
But
otherwise, other than this acute infection meeting. Okay, other than this acute infection, they have no other like underlying comorbidities that would make them immunosuppressed. Okay, and thank you for allowing me to clarify that. Yeah. All right. Okay, so when you look at this definition, okay, it's pretty much safe to say, pretty much almost all of your septic patients are going to have some degree of SIRS. Just looking at the numbers by definition, do you agree with that? Okay. But again, the caveat is that not all of your SIRS patients are going to be septic. The important thing is to keep in mind that this process can happen outside of acute infectious etiologies. Okay, and so at the molecular level, the triggers, okay, if you look at what the triggers are, there is what they call damage-associated molecular pattern, or DAM, okay, and burns will do that, it's damage. Think about it from that perspective. Trauma, there's damage. Acute aspiration, okay, you've got stomach acids going into the lungs causing damage. It doesn't have to be infectious. The acids themselves will cause a pneumonitis and cause damage. Pancreatitis, there's damage. So you can go through each of these and see, yes, there's damaged tissues. Anytime there's damaged molecular pattern, it's going to stimulate an inflammatory response. If it becomes exaggerated, then you have SIRS. Pathogen-associated molecular pattern. So this is where these would be pretty much your infectious, okay? And so these are two different molecular pathways for it to occur. One is through damage to tissues, the other is through pathogens. Okay, so in the case of infection, if you take infection. We have a light today. Infection, okay, it's gonna lead to inflammation. If there's successful containment, okay, so infection leads to inflammation. No, great, go ahead. So it's temperamental. So if it's successful containment, then you're gonna end up with resolution and recovery, okay? But if that's not the case, and it goes unchecked, that's when, or the infection goes uncontained, that's when you can have all of these different components. Immune suppression, okay? Inability to contain, even worsens the ability to contain the infection, so the infection can run rampant. Okay, and then you have endothelial damage. Okay, you can have barrier dysfunction, epithelial dysfunction, again, another barrier dysfunction. And so what ends up happening is you get multiple organ failure. You can have hypoxemia, cell apoptosis, okay, and once you get to the point of irreversible ischemia, then you're gonna trigger a cell death, which then, if it's not programmed cell death and it's ischemic, that is going to increase your inflammatory response and even perpetuate the condition. All right. So breaking it down, you know that we have both pro-inflammatory and anti-inflammatory. Okay, cascades, they're just check and balance system. When that gets out of balance, okay, then you're gonna have the patho. So stage 1, you can have local, and the goal is to contain the infection or the inflammation. Okay, in stage 2, there is early compensatory anti-inflammatory to try to maintain that balance between pro-inflammatory and anti-inflammatory. Okay, and in stage 3 is when the scales tip, and they tip in favor of pro-inflammatory. And that's where you can end up with the endothelial dysfunction, coagulopathies, activation of your coagulation pathway, which then is going to lead to DIC and multiple microthromboses in multiple organs. Okay, because it's a consumptive coagulopathy, and you're gonna end up with these microthrombi that go everywhere in the body. Okay, and the stage 4 is actually the state of relative immunosuppression, where the body can't mount a response fast enough. Okay, and that's gonna lead to an increased susceptibility to infections when you're in a leukopenic state. And then stage 5, which is your multi-organ dysfunction. Can a patient present or develop heart failure as a result of SIRS? Yeah, it's an organ dysfunction. Yeah, if the heart becomes hypokinetic, it becomes hypoxic. And it becomes hypokinetic, what's the net result? Less squeeze, right? It's a pump failure. Does the patient have to have LVH or decreased ejection fraction prior to this? No. No, it's the global kind of hypoxia that leads to the inability to produce ATP, which is necessary for your myofibril contractions. So it doesn't pump, it doesn't squeeze real good, becomes slow. Yes,
So would that be considered a cardiogenic shock, or would that still fall under?
septic shock probably, if it's due to infectious etiologies. Otherwise, it's due to SIRS and it would be it's not hypovolemic, it's not neurogenic, it's neurogenic,
Isn't cardio
hypovolemic,
distributed?
septic, distributive.
Septic is distributed.
So it might fall more under septic shock kind of thing, even if it's not necessarily sepsis, it's SIRS related. So. All right, so looking at sepsis specifically now. Okay, and realizing that it is the leading cause of death in the United States. People who are septic, mortality rates about 20%. Okay, but those who have experience, like all your healthcare experience, where do you see sepsis the most, and what kind of age group?
Elderly.
Okay, so it can be neonatal or the elderly kind of. And there's a lot more, I guess there's a lot more older people in this world right now than there are neonates. Okay, and so, yeah, the pendulum's gonna shift there. And then, of course, the people who may have other underlying pathologies, and comorbidities. But yeah, it tends to be an older patient that tend to be more prone. Why do you think that is? Yes, the senescent white blood cells, the sentries who are sleeping on the job, they get, their inability to sometimes mount a response, all their comorbidities, diabetes, et cetera, et cetera. Okay, so yes, they're the ones who are gonna be most at risk. But it can happen in anyone, so you always have to keep, an open mind and look for the signs. Okay? So sepsis, SIRS with infection, okay? But even out of those, only 28% will have true bacteremia. Okay, so even if in sepsis, okay, patients do not have to be bacteremic. You can have a full-blown pneumonia and become septic and have signs and symptoms of sepsis. Here, what's the big one you hear about in older patients? Yes, urosepsis, you got it. And what's the most common organism?
E. coli.
E. coli. And so, what kind of bacteria is it?
Gram-negative raw.
Gram-negative. So what does it have on the outside? That coat, right? With LPS,
More excited.
which equates to what?
You just sound stoked to be here.
Say it, yeah. Yes, endotoxin. Endotoxins. Very good. Are you seeing the different connections? Okay. And so the toxin can get into the bloodstream and be released. And that toxin is what can trigger this pro-inflammatory cascade without the bacteria and without the patient ever being bacteremic per se. Okay. So respiratory tract, GU tract, other abdominal sources like the gallbladder or the colon, devices, lines, central lines, portacaps, Foley's. Okay, and then you always have to think wound or soft tissue infections. Okay, so your gram positives, especially staph, are most common, especially with your line infections and true bacteremia. But always think about your gram negatives. Okay, and Candida infections are increasing because patients are living longer. They're living longer with more diseases, more comorbidities, and they have a certain degree of immunosuppression. Severe sepsis, that's when you have sepsis with organ dysfunction, low blood pressure. You know, and septic shock is really the final stage of that. Okay, and true septic shock is when they're not responsive to fluid resuscitation. So in that case, what do we have to give them? Right, pressors, vasopressors, to try to bring their blood pressures up. You got it. Right, so that's the true definition of septic shock, is when it doesn't respond to fluid resuscitation. Always look for those signs of hypoperfusion. What's easy to see?
Like your periphery,
Periphery, and what do you expect to see?
like lessening pulses or cold, actually pale, kind of that.
Correct, and modeling.
Mhm.
MOTTLING, modeling. Okay, so cool, pale periphery, they can be cold, clammy, diminished peripheral pulses. And you sometimes will see that modeling where you see it's like weird, like lacy, like veins, kind of this weird pattern on the skin. You should look it up and see if you can get an image in your head of what modeling, peripheral modeling looks like in septic shock. Or sepsis. Yeah. So. All right. So it's not that much different than SIRS, truly. It's really the same process, it's just you have a pathogen. And, you know, some of your, so this takes on the pathogen associated molecular patterns, you have that kind of damage. That, you know, it has to do with the type of bacteria or virus, how virulent is the organism, does it have endotoxin, you know, et cetera, et cetera. And then it's going to activate your white cells, your cytokines, your complement system. All that is gonna create this massive inflammatory response. It's gonna shift that pendulum over to the pro-inflammatory side. And you can end up with sepsis or septic shock. Being so contrary today. I've heard everybody's been having problems with the computers. Okay. So this is actually going into details about the hemodynamic alterations in sepsis. Okay, so what happens hemodynamically? How does that blood pressure drop? How does the patient get, you know, peripheral shutdown? So, and ultimately, it is that lack of tissue perfusion, low blood pressures, unable to perfuse the tissues. Tissues needs oxygen to manufacture ATP for normal cellular functions. So without aerobic metabolism or full aerobic metabolism, then you're gonna end up with cell dysfunction and ultimately death. Okay, so in shock itself, your SVR is actually elevated to maintain blood pressure. So your systemic vascular resistance is elevated. And it's in order to try to maintain, so you peripherally, so that you can maintain central perfusion. And so, you know, the more hyperperfused they are, the more they try to extract oxygen from the red cells. And that's gonna lead to a decrease in your pulmonary artery oxygenation. Okay? Early septic shock, you're gonna have inappropriate arterial and venous dilatation. So they're early on, hypovolemia is due to this vasodilation effect that then loses central perfusion, that you can't shunt all the blood into the central. And so in that particular case, as you get this overwhelming volume in the periphery, and that vasodilatation is going to increase the capillary permeability. And so plasma can actually leak out into the extravascular space. Okay? And then in order to compensate, the heart is going to try to increase. Okay? So that's going to be a compensatory problem. And then as the heart increases, it's going to consume more, it needs more oxygen. And when it's not getting enough, it's going to then essentially become dysfunctional. So when you have this hyperdynamic circulatory state with blood in the periphery and plasma leaking out, it's going to lead to a maldistribution of your blood flow. Okay, nitric oxide is going to be released. That's going to vasodilate, and it can actually lead to more hypoperfusion. Okay, and so that ultimately it's going to suppress the cardiac output. Okay, so initially the heart's going to compensate by increasing, which is that increase in heart rate, that increase in pulse. Later stages, then it's going to decrease because it's not going to get the oxygen it needs, and it's going to become dysfunctional. As far as what happens in the vasculature and the organs, at this point, hypertension is going to occur. You've got all these vasodilatory substances, nitric oxide, you've got plasma that's leaked out, your pressure's dropped, and you're not able to respond to it in, you know, in severe sepsis. Okay. And so that high cardiac output failure, so it's going so fast, it's beating fast to try to compensate. Ultimately, that's going to lead to failure. And so that's going to lead to systemic failure and hypotension, hypoperfusion. And so at some point, and then it doesn't even respond to vasopressor therapy. So initially, it doesn't respond to fluids, but long-term, it won't even respond to vasopressors. You know what they do next? Just in that particular case, when you have distributive shock.
The crash.
Was it the last time? No, no.
Get the crash.
They do an intra-aortic balloon pump.
Oh, the balloon.
Yeah. Yeah.
Not the full.
That's
Obviously.
That's like a last ditch effort. Yeah, the intra-aortic balloon pump. So anyway, but this is a bad case, what bad place to be. Okay. And so the terminal process is really multi-organ failure. Ultimately, all of these organs are going to fail. Why? Because they're not being perfused. They're not being perfused. So waste is going to collect, metabolic waste is going to collect. You're going to have acidosis. And you're not getting oxygen to make more ATP. The cells are gonna get to that point where all those different, ion channels and ATPase pumps that keep our cellular electrolyte levels, regulated, pumping calcium out, pumping sodium out, pumping potassium in, they're gonna fail. And ultimately, it's gonna lead to multi-organ failure. And even the vessels, keep in mind that they are functional cells as well. And so you can have, microvascular failure. Okay, if patients have 3 or more organs failing, so kidneys, respiratory failure, pancreatic failure, 3 or more, 70% mortality rate, which makes sense. Totally makes sense. Okay. Respiratory failure occurs in about 20% of your patients. Okay. And then with that, they can end up with ARDS. It's not true heart failure in that particular case. They can end up with acute respiratory distress syndrome because of all the increased capillary permeability and the leakage of fluid into the lungs, which is what we've seen with COVID. Okay, and so these patients, it's very, very difficult to oxygenate them. And mechanical ventilation doesn't even work. Lasix doesn't work. Okay? Lasix is for true heart failure. It's not for ARDS because it is not cardiogenic failure. It is respiratory failure from an increase in your capillary permeability and capillary leakage, and all the fluid extravasates into the lungs, which they did just become wet sponges. And that means with that, they have poor compliance, not able to expand, not able to retract. Okay, they can't diffuse, the oxygen can't diffuse over this wet, soggy sponge. And so these patients have non-cardiogenic pulmonary edema, and it's very difficult to treat. Okay, kidney failure, about 15%. So these are your 2 most common organ systems that fail. And it's multifactorial, but a lot of times it ends up, we add insult to injury because, especially in the case of sepsis, what are we giving them? Big gun antibiotics, right? Multiple antibiotics, broad spectrum. We're trying to cover everything. They get vanc, they get gentamicin. Okay. They might get Zosyn. Okay, so you have all these drugs going into this patient. Well, we know aminoglycosides are renal toxic. So not only do we have a perfusion issue, now we're giving them renal toxic or nephrotoxic drugs on top of it. But it's a choice you have to make. You follow the protocols. Okay? And then if we're trying to image these patients, you throw some dye on top, some contrast, iodine, or gadolinium, or whatever you're using. All that gets filtered by the kidneys. And yeah, it can have a very negative effect. Okay, and so, you're not wrong. You're not, and Lord knows you're not going to save everyone. Right? And so
Sure.
my advice is to always look for the signs. Look early. If you have a suspicion, monitor these patients more closely. Okay, and intervene as quickly as possible. And realize that you're not going to save everyone. You do what you can follow the protocols, but always be on guard for these complications. It's better to err on the side of caution than it is to try to play catch up. after they pass the point of no return. Okay? That's my best advice. HIV. Are there any questions on SIRS and sepsis? Pretty interesting though, really, isn't it? Yes, Ajay. Okay.
Is there something there about not better explained by something else? This tachycardia and tachypnea, like asthma exacerbation, do they qualify as SIRS?
No, but with a typical asthma exacerbation, yeah, you can have tachycardia, simple question. That's a good question. You know, no, I think it's, in that particular case, you treat the asthma exacerbation and you see where the patient is. But could a bad asthma exacerbation lead to SIRS? It could, probably not. Unless there's, maybe it's due to an allergy, like an acute allergy that triggered it. And in that particular case, yes, we can. Okay, because of the cytokine and inflammatory response that occurs with mast cell release of all those cytokines. Yeah, I remember, we had, I think I was still a student. I was still a student and, I was in the ER, doing my ER rotation. And we had somebody come in, it was a young person, like 21 or something, they had a cat allergy and was exposed to cats. And had an acute, like, it was truly like an anaphylactic reaction and was cyanotic, and despite intubation and everything else, the patient died right there in the ER. Epi, the whole 9 yards, patient died at like 21 years old. Yeah. So you get that point of no return, even in those cases. Relatively recent statistics, 11 people die every day from asthma in this country. You would think not, but they do. All right, HIV. Good questions. I think Dr. Noel did a really good job of going over this, the retroviruses and the fact that HIV-1 is mostly it's mostly what we see in the United States. We see it in Europe and Central Africa. HIV-2 is mostly in West Africa. And it's similar, but it's a much slower immunosuppression syndrome. So, and it does tend to be resistant to our drugs, which is important to differentiate. But essentially, you're going to initiate therapy based on the presumption that it's HIV-1 plus the EIAs now. The newer tests differentiate. Once you test positive, they differentiate you between HIV-1 and HIV-2. So that is a huge help. You know how it's transmitted, and you know, US versus worldwide, very different transmission causes. I'm trying to choose the right word here. So in the United States, it's mostly there's still a lot of needle sharing and drug use, and that's associated with as well as sexual contact. However, heterosexual contact worldwide is the #1 cause. Okay, heterosexual contact is the #1 cause worldwide. And, you know, the seroconversion actually occurs once the whole thing, if you look at the word, it's seroconversion. It's when you have the development of antibodies in your serum, in your plasma. Okay, and that's essentially when somebody's seroconverted. That window period typically from time of exposure to seroconversion, it's typically between 1 and 3 months, but it can be as long as 6 months, depending on the patient, depending on the viral load at the time of exposure. Okay, so if you have a high viral load from the contact, okay, and that the recipient gets a high viral load, the seroconversion may occur much more quickly. Okay, just because it's gonna overwhelm the immune system and it's gonna start replicating much faster to deplete the CD4 count, CD4 cells. And so the seroconversion can actually occur much more quickly, and it depends on the person's immune system. Okay, and so Dr. Noel also did a really good job of talking about the structure of the virus, and the importance of the structure has to do with the medications that we use to target cell, the viral entry into the cell and viral replication. Okay, and so if you think about again, I've shown viruses before. This one has the lipid outer coat. It's got a dense, electron dense core. It has 2 copies. The core actually has 2 copies of RNA, plus a capsid protein and 3 viral enzymes. Okay, and you can see where the drugs target these. They target the receptor on the outside of the cell for entry. They target the protease. You have protease inhibitors. You have reverse transcriptase. You have RTIs and integrase. So you have all of these different drugs, and that's what they're targeting. Okay. As you know, they have predilection for your CD4 and T helper cells, CD4 positive T helpers, and so they also have a predilection for macrophages and dendritic cells. So they deplete more than just your CD4. Okay, and you know that the CD4 function is to recognize foreign antigens, activate B cells to produce antibody, start the cytotoxic activity of your CD8 and natural killer cells. And so, as well as to influence macrophages and monocytes. So, by targeting these CD4 cells, essentially it decreases the activity level of some of these other immune cells. Okay, and when new viruses are produced, upon release, they do destroy the host cell, which is how you end up with depletion of your CD4 count. And now it should make sense to you when the CD4 count gets down below certain levels. If you look at the functions of your CD4 cells, now you can see why you have all these opportunistic infections. Because if they can't orchestrate CD8 activity or natural killer cells are natural immune cells. They can kill pretty much anything, any pathogen. But your CD8s, these are your T cells. This is fungal infections. This is why fungal infections become a problem in this particular patient group. But your natural killer cells also kill viruses. So this is why CMV and CMV retinitis becomes a problem. Tuberculosis, again, T cell activity. It's an atypical bacteria that requires T cells to be killed. And without them, and without that stimulation by the CD4s, then TB, all these can go unchecked. And so, yeah, the CD4 cells are critical in this whole orchestration and protection against pathogens. Okay, this just shows you a different diagram of the virus with the envelope, the lipid membrane, the different receptors on the outside. And so you can see where your different inhibitors work. There's the different enzymes and your 2 RNA strands. And this just kind of shows you how, so the virus is the virus is on the left, and then the depiction to the right is how the virus attaches to the CD4 cell, enters it, activation of reverse transcriptase, incorporation into the genetic material, and then replication and new virus being made. And when it buds out, it takes that lipid layer and coats itself all over again. Okay, so this goes through it step by step. This is your life cycle. So step 1 is the binding. Your step 2 is internalization and uncoating along with reverse transcriptase. Step 3 is integration into the host DNA, where it can either persist or reproduce. Step 4 is replication. And then step 5 is the dissemination of new viruses. So that just kind of breaks it down step by step. Okay, this I thought was interesting. This is an electron micrograph of budding HIV viruses from an infected CD4 cell, which I thought was pretty neat for you to see how it actually, the diagrams are pretty accurate when it comes to what actually happens with the virus. And it destroys the CD4 cell. Okay, there are 3 phases of infection with HIV. You have your primary infection phase. And this is when patients have kind of this general malaise, almost like a infectious mono syndrome that lasts a few weeks. That doesn't mean that's the majority. There are individuals who will have an acute viremia and have an acute viral infection. Okay, which is completely different. And they are like, they are sick, like they have high fevers and body aches, like they've got the actual flu, sore throat, lymphadenopathy. So HIV has to be on your list. An acute HIV infection has to be on your list with patients who have risk factors who present that way. Okay. Then there's typically a chronic asymptomatic phase or the latency phase, where the virus is reproducing, it's destroying CD4 cells, okay? And a lot of these patients will just have this persistent lymphadenopathy. That's not uncommon. And they might say, well, yeah, I had this kind of virus in the spring. I tested negative for COVID, I tested negative for flu, but, I've just had these, lip lumps in my neck ever since. And now I just feel fatigued, okay? But yeah, it can persist for years, and on average, about 10 years before they actually become symptomatic. Now, yes, there are all ends of the spectrum. It's the AIDS phase is defined by either an AIDS defining illness, okay, or a CD4 count less than 200. If we don't intervene, we don't treat, they will usually die within 2 to 3 years. Once they've been diagnosed with AIDS. Realize that there are both, infectious and neoplastic complications of HIV, especially once it becomes AIDS. Okay, when you don't have that immune support, viruses that have been latent can then progress. They can trip those oncogenes, and they can lead to things like Kaposi sarcoma. They can lead to all kinds of cancers, but you can see, as far as this diagram, I thought was interesting because it shows you some of the different infections as well. And so diarrhea, from protozoans to bacteria to viruses, they can have lymphomas, B-cell lymphomas. They can have lymphoma in the brain. So. Just kind of a summary slide of different things. Are there any questions on it? Okay, so my focus is truly on the CD4, CD8 relationship. Okay, and how that works. And why is it excluded? So that's really my focus for HIV. From a pathophysiologic standpoint. Any questions?